Hello, everyone, and a very, very good day, everyone. And today we have yet another interesting chief guest with us. And this is podcast number 11, where we are talking about kidney health and we are talking about dialysis to transplant journey. And this is very important topic, and it will be very, very helpful for everyone. That's the reason we have invited Dr. Guhan, and who is master and specialized in the same field. And doctor will walk us through on various aspects how we can improve overall the kidney health and how we can improve the overall well-being also as well. And uh, and what I will do, I will share my screen just to give the quick intro of a doctor. And this is the topic we are going to discuss today. The topic is that the dialysis to transplant, and this is none other than Dr. Guhan. Doctor, I'm taking so privilege and honor to welcome him for our uh, YouTube channel as a chief guest for him. And then just to briefly discuss about his education front and then professional career, he's done the MBBS and then MD in general medicine and nephrology, and he has been associate as a assistant professor, National Center for Aging, and then he has been treating various patients at consultant nephrologist at CURI 1. I'll keep that address also as well, just in case if you wanted to meet him, you can meet him also as well. And mentorship and learning, he has been taking so much privilege and associated with the Dr. Muthu Jayaram. Muthu Jayaram has been there with us for almost three times, was given the name and the coin Dr. Guhan to be invited. And I said, it's a fantastic idea. Why not? And now we have Dr. Guhan also with us. And I really like the quote which he has: every patient is a teacher, continuous learning every day. And while I'm taking absolute privilege and thanks to Muthu Jaraman also as well for tossing up his name. And I'm also very happy to promote whatever the initiatives we can bring to have the good healthy everything, right? With that, and once again, a great, great, great privilege to welcome Doctor. How are you, Doctor, today?
Hello, sir. I'm doing good. Thank you. Thank you so much for that very kind introduction. It's been an honor to be here, and very excited to hear about this when Muthu ma'am told me about this idea. I mean, it's an excellent initiative by you. I mean, to want to use this as a completely a health awareness initiative. Not many people come forward to do this, and just your idea was very inspiring to me and was very interesting. And as you mentioned, I mean, Muthu ma'am has been more than a mentor and guide to me at CURI. And the little time that I've known her, I've always been inspired by all the way she conducts herself, to the way she sees her patients. And she has ma'am has a lot of long term follow up patients. Around 30 years, the ma'am would have followed up patients, and families of patients, and the way she has a rapport and the way they believe everything that ma'am says and truly trust that doctor. That is, I feel, something that we are lacking these days. But somebody who truly trusts the doctor and truly believes that the doctor does something for their good, all those things. I mean, there are a lot of things that are always inspiring. And when ma'am told me about this opportunity, I just thought it's a wonderful idea, and really, really happy to be here. And thank you so much for the opportunity, sir. I just want to, hope that this is really educating a lot of people. And the main purpose of this is to try and, break that barrier between a doctor and a patient, and to try and very smoothly make sure that even a patient understands what nephrology means and what kidney health means and what dialysis and transplant means, which is the main theme around which I felt today's discussion should be.
Okay, wonderful, wonderful, doctor. So let's start with the ice breaking, and then, yeah, of course, you have a wonderful deck, and I cannot wait to see that deck also as well. So what inspired you to become a nephrologist, doctor? So, why nephrology? Why not the other domain? With that, we can go ahead and share your screen, and then keep going, doctor.
So somehow in when I was doing my MBBS from Tanjore, somehow surgery was something interesting to look at, but I felt I was not somebody who was very very good at my hand skills. So I decided never surgery would not be my cup of tea. So I said, okay, able to do medicine. And that's how the journey to MD General Medicine started. And it's very fascinating how each disease, never reads the textbook. We read something on book, but when it comes to a patient, it's a completely different condition that we're treating. And to see a patient as somebody who's undergoing a difficulty and us trying to make that person's life 1% better, there's nothing more satisfying and gratifying than that. And when I finished MD, somehow I didn't want to do specialization. I wanted to stay in MD. So then I said, okay, let us choose a subject that is as close to medicine as possible and plus inspired by mentors at the brothers. It was always inspiring to see such people. And I felt it was more of distilled medicine and refined medicine. You have to note every small lab value. You have to note every ml of fluid given, every ml of urine produced. It's more of a very refined medicine and a very purified form of medicine, which every drug, every dosage, every mg matters. And that's why I think it inspired me. And each day becomes a journey. And as I said, each patient teaches you so much about the science of nephrology.
Excellent, excellent. And as you rightly said that, being doctor, you must need to have a attention to details and all that, as you very well quoted, doctor. Yeah. Yes, doctor. The stage is all yours, and please walk us through the detail which you have prepared in beautiful slide.
Sure, sure. Yeah.
Yeah. Yes, doctor. We can see a screen. You can go. Yeah.
It's my scene visible, sir?
Yes, yes,
Yeah.
yes, 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 yes.
Yeah. So I just thought we'll walk through a few patients and a few patient stories today. And that way, maybe, it's a story that we would have all seen somewhere. And I thought this will make an understanding of the science of nephrology better, especially for a patient. So this was a 30-year-old gentleman with no known comorbidities. He was not a smoker. He does not consume alcohol. He had a history that he was born in India. He was somewhere near Kerala, and he'd worked in the Gulf for around 8 years. And it was pretty heat exposure, strong around 10 to 12 hours of day. And he was diagnosed with kidney disease. So they said this is risky to be here. So please go back to India. And he came with a creatinine of 1.9, and the scans showed a contracted kidney. So when the kidneys are shrunken on ultrasound, that almost says that it is a chronic kidney disease, that it has been a long drawn process and the kidney has lost function. So in this fear and anxiety, he came to the OPD and he asked a simple question, sir, I've been told to have CKD. So what does that mean? So before we understand about chronic kidney disease, the first thing that anybody should know when you understand kidney disease is that there is a word called as creatinine. And I'm sure we have heard about this word called creatinine on multiple places, but we never realize what its actual purpose is. So to put it very simply, when your kidney function declines, your creatinine level increases. So it is a very simple logic that when the kidney function starts dropping due to multiple reasons, it can be due to age, it can be due to BP, it can be due to sugar, it can be due to painkillers, it can be due to multiple reasons. And because of this, when the kidney function drops, the only reflection is that the creatinine level goes up. And why it is important to monitor creatinine is that kidney disease, unfortunately, doesn't have symptoms. It takes about 50% of the kidney function to be lost by the time you have any symptoms. The symptoms could be facial puffiness. Symptoms which is very commonly missed but very significant is froth in the urine or bubbles in the urine. All these symptoms can happen early, but most of the time it happens at a very late stage. And by that time, the damage is already caused. So, which is why it is very important that we do a master health checkup when we cross the age. And we do a. So, this is the first important. Sir, please give me a medicine. I want to lower my creatinine level. What is important to understand is that it's not like BP or sugar, when you can give a medicine and lower your BP, you can give a medicine and you can lower your sugar. But what happens is there is no medicine to lower the creatinine because creatinine is just a marker. It gives you an idea that the kidney is not it goes out when the fire is in the building. So that is what a creatinine is. So the kidney is burning, and the fire alarm that rings is your creatinine. So if you ask me, sir, can I just switch off the alarm? So that's the kind of question. Is there a way to lower the creatinine? That's a similar analogy. So there's no point in lowering the creatinine. And if somebody is telling you I have a medicine to lower creatinine, they're obviously, exploiting you is what I would be. And we as nephrologists, if ever there was a medicine to bring down creatinine, we'll be the first people to prescribe it. So that's very important to understand, why the creatinine goes up and why it's not possible to give a single medicine and bring down the creatinine. It's more of a treatment of the cause. We try and identify why the creatinine is going up. Is it due to uncontrolled BP? Is it due to uncontrolled sugars? Is it due to long duration of BP and sugars? Is it due to an obesity? Is it due to some painkillers or drugs or native medications? Is it due to their lifestyle changes recently? All of this can end up causing kidney injury, and we try and correct that cause, and that is when the creatinine will be controlled. And this is another thing that off late is being another myth among the community. People think that there is a blood test called EGFR. So it is seen on your many of your estimated GFR, which just uses creatinine. It puts it in a formula for your age. We commonly use the CKD EPI equation, and it helps to tell you again what your kidney function is. So it is not a blood test. Please understand. Please do not, spend money doing an extra money doing your EGFR test because it is nothing but a calculation. It is not a blood test. But what this EGFR tells you is this is your general picture to show your what the staging of kidney disease is based on your GFR. So the value that you see on your lab report, if it is more than 90, it is grade 1 and this is relatively normal. As the GFR goes down, this is when you have the possibility of a kidney function drop or a kidney failure. So to put it simply, when your EGFR is talking about end stage kidney disease. So, here again, we need to understand that there are two types of kidney injury. One is acute kidney injury, another one is chronic kidney disease. What do you mean by acute kidney injuries? Sometimes you would have probably a fever, or you would have had a urinary tract infection, or you would have had a recent painkiller intake. Any of this, you would have had normal creatinine. Your creatinine is around 0.6 to 0.7. When you have an issue like this, the creatinine goes up to 1.3 or 1.4. We correct the cause and it comes back to zero point 0.7. So this is an acute kidney injury, something that has come off late, come recently, hit the kidney, recovered, kidney is back to its normal function. The other thing that we're talking about for long-term dialysis, transplant, and all that is for chronic kidney disease. That is when step by step, with age, with multiple factors, the kidney drops its function, and then it's more of like how you have joints degenerating, you have your vision blurring, you have your hearing sensation getting lost. Similarly, the kidney starts to slowly lose its function. That is your chronic kidney disease. So today we'll predominantly be talking about the second part, which is your chronic kidney disease. And to realize which stage of CKD the patient is, this chart helps to let them know based on the estimated GFR. So, moving on to our second patient. So, he was a 51-year-old gentleman, the classical history of 7 years of sugar, 3 years of hypertension, BMI around 29, mild leg swelling, and he was diagnosed as CKD 4 years back, and that time the creatinine was 1.9. Mostly, these patients are on periodic follow up. They are advised medicines for BP, for sugar, for their protein leak, advised lifestyle measures, and they are asked for periodic follow up. Sometimes what happens, either they miss follow up or they miss medicines or they change dosages or they, some point of time, these patients come back, say 7 years later. So this patient came 7 years later, and that time he had leg swelling, he had a decreased urine output, and he became breathless. At that time, we saw his creatinine. His creatinine was 7.5. which comes to a formula. If you put it in the formula, it comes around 6 ml GFR, and the potassium levels were 6.3. So these are all emergency indications to thing that always people don't understand is hemodialysis has evolved a lot over the years. Initially, it was somewhere around 1950s and 60s, and prior to that, dialysis used to be a very horrible, very painful procedure, high degree of complications. People used to keep vomiting. We used to use acetate for dialysis. This is the dialyzer in this image. And this is what is used to purify the blood. This used to be a cellophane paper, what we used to wrap our burgers and our wraps. We used to use a lot of that cellophane paper to try and filter. The tubings were absent. There were so many complications that were there. And the other problem when dialysis started out was not everybody had access to dialysis. In fact, there's very interesting history if people are interested to read. There was something called as a God committee where they put in 4 or 5 people in charge in that country, and they said they can only decide who can get dialysis. So if the God, they were nicknamed the God committee. So if they approved, you get dialysis. If you didn't get dialysis, you would die. That is how scarce our resources were, and that is how initially it was such a painful procedure. And we fast forward to 2025, 26 now, and we see that there is so much of advancement in dialysis. So it is a simple process wherein, if you can trace this out, blood comes out of the body of the patient. It goes through a dialyzer, which is where the purification happens, and the clean blood returns back to the patient with all the used fluid entering out as the exit. So here you have a dialysis fluid which is passed in through in this direction, and the blood flows through here, and by multiple mechanisms, the blood is purified. Fresh fluid free keeps coming in, fresh blood keeps coming in, pure blood returns, and the dirty water is cleared. So this is how this dialyzer is what does your kidneys function. So basically, it is a brilliant invention in that there is no other option in any other organ of the body. If your brain is not functioning, you don't have an artificial brain. If your liver is not functioning, you don't have an artificial liver. But this is a wonderful intervention of science wherein you have an artificial kidney. You have a way to clear out your waste, and it has come to the extent that people come very casually to dialysis centers, do their dialysis, and go about their routine lives. And there is the other misconception about dialysis is that it is painful. Only this part when you insert the needle is painful. Apart from that, that 4 hours of dialysis that they do, patient has no pain whatsoever. In fact, if you visit our dialysis unit, you will see patients watching movies, you will see patients listening to devotional songs, you will see patients, gossiping about each other's family issues. You will have patients who are reading storybooks. You will have a completely you would think I'm saying this without thinking, but it's a very fun 4 hours for them when they lie down, they discuss all this, and then they go back home. So it started off as such a scary, such a uncomfortable way of treatment, but today it has come to the extent as such a comfortable way of living. So basically, to give you an idea, patients just come for 4 hours, either 2 days or 3 days a week, and the 12 hours alone, they're in the hospital. They do the work. So this filter does the work that the kidney does. It's like almost like, you have a dustbin at home. 3 days, all the waste accumulate. And once in 3 days, you clear it and put it in the main bin. And so it's just replacing the kidneys function. It doesn't treat the kidneys. It doesn't solve your problem, but it helps to clear the blood of the waste that have accumulated. This is how dialysis actually helps the patient. And before even one session of dialysis, 2 sessions of dialysis, patient crossing that was such a difficulty. Now there are, patients who are on dialysis for 15 years, for 20 years, and they are doing well. So, and again, accessibility, as I said, we're talking about God committee. Now we have dialysis centers at almost every nook and corner of the city and the state, where we have all GH, all government headquarters hospital equipped with dialysis services. So the reach of services is also has improved tremendously. And is this always a very smooth process? What is the major hurdle that we identify? I think the problem that we as nephrologists find out is that the finding a good access. So you need a way to get the blood out of the patient. And for that, there are multiple options. So the first option here is your catheter, which is a plastic tube which is inserted, which is used for any emergency dialysis initiations. Or you can have like an AV graft, arteriovenous graft, or you can have an AV fistula. So these are your three options. And somehow getting this is very difficult for every patient. This if this fails, everything fails. So this is why we call it the Achilles heel of our hemodialysis. So if you want to ask me, sir, which is the best option to do dialysis, it is always your AV fistula. So this is your best option because you're not using any plastic. There is no outer plastic tube which can get infected, which can get contaminated. So basically, two parts of the artery and the vein are tied up together, and this way you put a needle and you do a dialysis. The only thing is this requires your time to use. So this time to use is slow. If you do a fistula today for a patient, it takes around 6 weeks for that fistula to mature. And it's not a fixed number. Sometimes we see it maturing in 4 weeks, sometimes it takes around 8 weeks. So if you want somebody to do emergency dialysis, this is not an option. This is where it becomes a major issue because our patients are mostly anxious. I mean, it's understandable. It's a new form of therapy according to them. So they're like, sir, I don't want to do dialysis. Give me anything else, I will do, but I don't want to do dialysis. So they think of it as a life sentence for them, but it's actually a way to liberate yourself and to get back to normal life. I mean, and again, that is another major misconception that I've seen a lot of our patients, go through. They think that if you're going to dialyze, you're going to be sitting at home and doing nothing else. Absolutely not. There are patients who are working in the police, working in the armed forces. There are people who are working as librarians, teachers, AC mechanics, auto drivers from all cadres who come here, do their dialysis, and the remaining hours of the week they work. They're in fact the breadwinners of the family. They change their slots accordingly. They will tell me, sir, I'm working in a school, so I will come for dialysis at 4 o'clock in the afternoon. So they fine tune it to the extent of it not even affecting their routine schedule. That is how it is. It has become like a customized treatment. And to be honest, many of our patients know more than us on dialysis because they become so comfortable with the process, and they know the mechanics, and they know what happens. They know when their fistula is good. They know when their fistula is not having good flow. When the alarms, they teach us on what happens. That is how much dialysis, almost runs on its own on many of its times. So AV fistula is what I would say is the best access if it is feasible. AV graft is another alternative. But when you have somebody like our first patient who had to come with an emergency indication for dialysis, we end up putting a catheter like this. And the advantage is the immediate use. So you can immediately use that catheter. So fistula is the best, graft is a good alternative, but catheter is the last resort. So what we generally do is we put a catheter, we do dialysis at that period of time, we immediately create a fistula. For 6 weeks, we manage with this, and then after a period of time, we switch them to the AV fistula. So this is not the only method available for dialysis. There is another method called as peritoneal dialysis. So this is something that has improved a lot of rate. Again, accessibility has improved a lot. We didn't have connection, we didn't have contacts, or we didn't have logistics to bring this equipment into our country until a very long time. But now we have something called as continuous ambulatory peritoneal dialysis. So this is a way in which you can do dialysis with a tube inserted in your stomach. So this is peritoneum means a lining cavity in the abdomen. We do a small surgery, put in a catheter into the peritoneum, and the patient and the caregiver can do dialysis at home. So what they do, it is just like when you wake up in the morning and you drink a glass of water. They wake up in the morning and put one bag inside their stomach through this tube. They close the tube, they wear their dress, they go to their work, and then during lunchtime again, they connect that catheter, drain the fluid, and then they put the next bag, continue their work in the afternoon. Night they come back, drain the bag, put another bag, and they go to sleep, and this goes on again and again. The only initial surgery is for this catheter to be placed, and after that, dialysis can be continued at home. So, why has this gained a lot of interest of late is that your activities are not impeded. For hemodialysis, if you really think about it, you need to come to the hospital either 2 times or 3 times a week. You come there, you wait, you need a caretaker, so a husband or a wife or a mother or a father is there. So there is a lot of caregiver fatigue, there's a lot of caregiver burden, and then there is out of pocket expenses of travel back and forth. So all of this is probably the slight issue with hemodialysis. And to avoid this, you can do it at home. It is a way to do it at home. It's a mode of home dialysis in a way. And the other advantage is it is done daily. So why is it an advantage? Is it more, you would ask me, isn't it more of burden to do it daily? It's because it's done daily, it's almost like your normal kidney is functioning. There is no accumulation of waste products. Sometimes what happens in hemodialysis, if we suppose we give them a slot and say, so Tuesday and Friday, you come and do dialysis at a 2 o'clock session. By Monday, sometimes they become very breathless or they have high symptoms. So because it's like your waste is accumulated to a high point. It's like you've not cleared a dustbin for 4 days, 5 days in a row. Because of that, the patient becomes symptomatic and they have to be restricted on how much food they can take or how much water they can take. But when you do it on a daily basis, this replaces and does it like almost like a normal kidney function. So they can eat what they want, they can drink what they want on a day to day basis. The only caution is that it requires an assistance from a caregiver. Doing it individually is slightly difficult. And because you're handling this catheter and you're not a medical personnel, you should make sure that you maintain your sterile precautions, washing hands prior to procedure. And we have like a training module for the patient and the attender, and we tell them how you can do it sterile. And it's not like you need to be educated. So we have seen people who have studied only up to third standard, but they would know CAPD perfectly and even better than a doctor or a healthcare worker does. It's more of just repetition of a period of steps. But then it requires care because when you do hemodialysis, the onus is on the hospital and the technicians. Whereas when CAPD is done, the onus comes back to the patient. So this is the major difference between the two. But the other thing is that this is something that is a major issue of late for us. So to give you context, when we do hemodialysis, the major barrier from the patient side is the access. The major barrier from the hospital side is to get in a lot of water. So I don't know how many of the people listening to this will know this, but to do dialysis for one patient for one session, we need around 120 liters of pure water. So for one patient for one session, we need around 120 liters of pure water. And this is pure water. Imagine the reject water, imagine the raw water that enters. So over a period of time, what we are really worried as even in the nephrology community is how long will we be able to sustain this? What can we do as a community to decrease our water use, and what are the ways that we can help save the planet when we continue to provide care? On the one hand, you can't deprive people who have a difficult disease and you want to help them get better and heal them in some way. On the other hand, you don't want to destroy the planet. Although CAPD, there is not much, not as significant water. Again, there you're using dialysate fluid. Again, so if they're using 3 bags per day or 4 bags per day, in month, one patient has around 120 bags. So there's a lot of plastic waste that is generated. So there are a lot of issues in both forms of dialysis. And although we do adopt a lot of green nephrology practices, is in, we have dialyzer reuse. We sometimes the plastic waste, we try to reuse the dialyzer adopting the required safety precautions. And then we try to, all the discarded water, we try and use it for either toilet purposes or for our watering of the lawns or watering of the plants. So, we make sure that the reject water, although it is rejected for dialysis, it is still a very pure form of water. So we use it for other practices and other ways in which that water can also be held. So we are doing our bit, but this is something that continues to bother us. And which is why even this year's World Kidney Day initiative was about how we can help the people at the same time protect the planet as well. So this is something that we as a community are still finding out solutions to this problem. So
One
coming back,
question,
yeah,
doctor. Yeah, one
yeah,
question, doctor.
sure.
Can we switch from the hemodialysis to peritoneal or peritoneal to hemodialysis? Can you
Yes,
please
yes,
put
sir.
some light on it?
Yeah, yeah, very nice question. Thanks. So what we generally do is before we start CAPD, sometimes the patient's creatinine and urea levels will be very high. So for the initial surgery, as I said, to put in this catheter itself, they may not be fit for the surgery. So what we do is we give a few sessions, 2 to 3 sessions of hemodialysis, and then we go ahead with this process of catheter insertion. And this catheter insertion also as like a fistula maturation, this requires around 2 weeks for it to get firmly positioned in this place. Sometimes the catheter can move, can migrate, this tip can go somewhere else, or this can move, change its position. So if there are all of these complications, they will have to continue hemodialysis until this CAPD works perfectly. And as I also said, there is a risk of peritonitis, which means like there is some infection or inflammation in the abdomen. So sometimes when this catheter becomes infected due to many reasons, it can be due to some, maybe sometimes having some pets at home, sometimes handling of the catheter. What happens is, for whatever, most of the times what happens, until 1 year or 6 months, the patient follows all advice strictly. But then at 6 months or 1 year, some kind of lethargy creeps in. They kind of skip one step of the process. They don't clean their hands, and immediately this kind of picks up an infection in the peritoneum. If that is the case, the initial treatment, we give antibiotics, we see if it works. But sometimes if it doesn't work, we end up removing the catheter and we give rest to the peritoneum for either 4 weeks or 6 weeks based on what infection happens. And then again, we put the patient back on dialysis, hemodialysis. If again hemodialysis they do have complications, we again switch them back to CAPD. So it's like an option can be, both can be switched over at any period of time, but mostly at the start when we offer the patient with options, we tell them you can take a call on which you would be comfortable with. Sometimes you don't have a caregiver at home, you won't have somebody to connect, disconnect, and it'll be difficult for you. And for some people, for somebody to come to the dialysis center and go will be difficult. They may have vision issues, they may have mobility issues, they want to take care only at home. So we offer both to the patient. We ask them to take a call on what is preferred. The initial choice is left to the patient, and it's like a shared decision making. But at any point we do switch over from both hemodialysis to peritoneal dialysis and peritoneal dialysis hemodialysis.
Wonderful, doctor. So, does the dialysis itself heal the kidney or damage the kidney, doctor?
No, sir. No. So again, it doesn't do both. This is another thing that many people ask. So, sir, I want to do dialysis, but within 2 months, can I get back to my normal life? It is never the same. So, as I said initially, if it is due to an acute kidney injury, if there is something that is suddenly affected the kidney, I have a case at the end. I'll probably add on to this at the end. That can recover your kidney function and get back. And even then, the kidney just supports the dialysis just supports the kidney function. The kidney heals on its own. It doesn't help in healing. At the same time, it doesn't cause harm as well. So the kidney has to heal on its own, and the dialysis just supports the kidney when it's not. It's like a substitute when somebody is not doing well. That is how dialysis works.
Very good response, doctor. Yeah. Please go on, doctor. Thank you so
Yeah,
much.
sure.
Yeah,
Yeah.
very well response.
So moving on to our third patient. So she was a 36-year-old lady. She was a known case of SLE. So systemic lupus erythematosus. This is kind of an autoimmune disease. She's been having it for around 8 years. And for 8 years, she had other organ involvement. Only for the last 2 years, she found out that it affected her kidney. At the time of diagnosis, her creatinine was 1.9. Because it was a autoimmune disease, she was started on some immunosuppression. Again, the problem with most of our patients is they have a lot of issues with taking medicines. So we have around 6, 7 medicines, sometimes even 8 medicines, and people are like, why am I taking so many medicines for so many years? I want an alternative solution. And then they ask people at home, they ask their relatives, and then their relatives have this one wonderful miracle story that, no, no, you don't go here, you go to one particular magic doctor who will give one medicine and everything will go. And then they believe that, and then they end up, uh, just one miracle option is one. It's understandable from the patient's point of view. They just want freedom from all of these medicines. So they even start feeling better taking those medicines. So they continue on that. But then sometimes things get bad and they end up coming back to us. So this is a common circle that many doctors and nephrologists will tell you that, there is a patient of theirs who started, we only diagnosed, we only gave them initial treatment. They were on good follow-up. Suddenly they lost follow-up, went in for native medications, and then they come back to us with complications. So this girl came back with a history of multiple fractures following trivial trauma. Another thing that is not understood about kidney disease, and many people don't understand, is that kidney indirectly has a major role in your bone health and your blood health. We see a lot of anemia, we see a lot of what we call mineral bone disease when there is kidney failure, which is why you have patients who are taking this erythropoietin injections and iron injections a lot on dialysis. Because the kidney plays an important role in producing a hormone called erythropoietin, which is required for blood to be produced. When there is kidney failure, you will have anemia, and that needs to be treated with these iron injections. So, and another thing is bone health. So, bone health, blood health, all of these are indirectly affected because of kidney, and which is why I always, though I'm a nephrologist, I'm biased on this. I always promote is the kidney is like the master organ. Everybody has this fascination with the heart somehow. I mean, I personally, to be very honest, until I was doing my 12th standard, I want to be a cardiologist because it looked fascinating. The first thing that we hear about when we see health as a symbol, you will see heart. And when you go to your undergraduate and you buy your first stethoscope, you're very excited to hear that lumped up sound. And it's always cardiology, heart is where the all the fascination comes. I was even telling somebody the other end, no, we even it's gone to the extent that even if you propose to somebody or you say love, it becomes, you talk about the heart and as the greatest organ. So it has always been a fascination for the heart, but to me it's always the kidney, which is a wonderful organ, which is like the silent guardian, which is like the real dark knight and the watchful protector of our body, which doesn't make any noise. It keeps going on in the background and does a lot of the work, and which is why it's so wonderful. Anyway, I'm debating here, but yeah.
Yeah,
So
one point, doctor, actually, you were
yes,
narrating one point is that so some patient actually so tend to follow the advice from the relatives. Sometimes the placebo effect also come into play, and they believe some of the medicine, and to some degree, to small degree, it helps. But actually, by the time indirectly the kidney health is getting worsened, right? So I think that is also you might, of course, you must have seen a lot of cases on this also as well. So can you
true,
just
sir.
slightly put some light on placebo effect, doctor, so that our
True, sir.
viewers can understand how it makes a difference. Yeah.
Sure, true. So this is something that is very true of late. Even in the era of information, like even people like you are doing such good work in trying to get out good information to the public. Because of this same avenues, a lot of misinformation spreads a lot more easier, and it's almost sensational when you say, "I have a medicine to bring down creatinine," and if on the other hand, if I say, "I'm sorry, I don't have anything to bring down creatinine." A lot of sensation will be there if I release a 30-second video saying that I have a magic pill to reduce creatinine. And see, this is again a topic of controversy. I don't know how much I can explore into it. But alternative medicines, this can be either your Siddha or homeopathy or Ayurveda, has a brilliant history, has a fascinating story as to how each of these fields of medicine have evolved. And if you read into literature, homeopathy or Ayurveda or Siddha was meant to be a natural form, a naturopathy in a way, wherein natural ingredients were adopted and diluted and a way contributing to overall health. This is the origin story of many of these sciences. But what has happened over the years is there's been a not a stringent regulation on many of these products, many of these items. There is no regulatory authority which is focused on this, which says that you should not use more than this amount of this element or more than this amount of this metal, and you don't understand what is actually inside. You have powders, you have small tablets, you have black colored balls, you have white colored powders, and you don't know what is actually content in that. You don't know. For example, if I want to start a new company, and if I want to produce even a simple drug like paracetamol, I have to go through multiple regulatory authorities, make sure that that tablet should contain only paracetamol, only 500 milligram, and only then I can probably think about introducing it into the market. But when it is a lot of the alternative medicines, the regulatory authority isn't as strict as what I would personally feel. And in addition, there aren't many trials which establish benefit. What we have seen is there is some content of a low dose of maybe a steroid, maybe an NSAID, maybe some degree of alcohol, maybe some what we're seeing commonly now is heavy metals. There are a lot of heavy metal toxicity which is adding on. We've even done analysis and found out that levels of mercury, lead, cadmium, and all of are higher in many of this. So I wouldn't blame the entire science. I wouldn't blame the entire field as such without knowing their entire history. But I feel that it is lost regulation, and that many times many of these compounds are present in thousands and 10,000s more than what they should, and which is why sometimes you have a feeling of well-being. You eat better, you put on some weight. Maybe it's the effect of steroid, maybe it's the effect of some element inside, but in the long run, this actually doesn't translate into good outcomes, and then we end up seeing a lot of the complications, and then by the time it's too late. And it's quite unfortunate because you're kind of exploiting somebody's insecurities or exploiting somebody's state of mind. They are looking, searching for a solution, and you're offering something without evidence. I feel it's not right. So, and this is something that people should be very, very aware of, should be very clear about. And today we have, it's not like you don't have ways to understand what is true and what is false. We have internet, and AI has actually improved so many things. And I can these days, even I feel very comfortable telling my patients, if you don't trust what I'm saying, or if you don't believe what I'm saying, put it on ChatGPT and tell me what it does. So it's a neutral way to, even talk to your patient. There's no more hiding. The information is all out there. And if patients are ready to take that in, and patients are ready to really analyze what they want to take in as a tablet, I think that would make tremendous change to our field and kidney health overall. Because what happens is, it's and the alarming and the sad part of all this is, these medicines are not cheap in any way. They're in fact expensive.
True,
But then
true.
somehow there is a belief and there is a trust that something that is marketed as natural is never harmful. And that word natural is what ends up convincing them. And supported by that is one story in the family of somebody taking one tablet and their problems disappearing. And that becomes, so what I tell them is, mostly it would have been a stone, it would have been an infection in the kidney, and they would have had water and they would have passed out, the creatinine would have come down because of that. But they will say that it is because of that magic pill, it will because of some mukar tekirei, and it is because of all of that. So what I tell my patients is, take all the fruits, vegetables, whatever is natural you can take, but any powders, any tablets and all that, without knowing what is inside, please don't consume. And that we would be the first people to put it out to the world if it's actually causing any benefit.
True, true, true. Well said, doctor. Yeah, please go on, doctor. Yeah, well
Yeah.
said.
So this was a lady. She came back with multiple fractures following her trivial trauma. So over a period of time, her symptoms worsened. Her urine output dropped to less than 100 ml per day, and she was started on hemodialysis. So when patient is on dialysis, the other option that you have, apart from hemodialysis, apart from peritoneal dialysis, and often there's another thing I want to talk about. This is something called as home dialysis. So these days you can do dialysis at home as well. There are ways to maintain the machine at home. The only thing is, the water that you use has to be running through your blood and coming out. So because that the cleanest form of water is what is important. So maintaining that purity, maintaining that cleanliness, putting a needle into that fistula, all those are difficult, which is why home dialysis has not yet picked up to a greater extent than probably in the Western world, but it is significantly improved, and that is another option that is there. So home HD as a whole, hemodiafiltration, then there is this peritoneal dialysis. And all these options are a better form of renal replacement therapy, or a way to improve the kidney's function. The best part is renal transplant, and which is why, so for her, she had her father who was a prospective renal donor. And then, so we had a complete evaluation for her father. So the most ideal renal replacement therapy is your renal transplantation. And to kind of give you an idea as to what are the transplants and how transplant happens, we should understand that there are two types of kidney transplant. One is a life related renal transplant, meaning that somebody in the family who is related gives a kidney to the patient with kidney disease. So this is a live transplant related from the mother or the father or the spouse or the brother or sister or grandfather, grandma, somebody in the family gives their kidney to this patient, and that is your live related renal transplant. The other option is a deceased donor renal transplant. We'll talk about this in a while. So this is another misconception that is commonly thing, and to be very honest, I didn't know it till I was in, say, MD general medicine. So this is our normal kidneys. Normal kidneys produce your urine, and it comes to the blood and passes out urine. I thought these kidneys will be removed and transplant will happen, but the
Even
actual
I do
truth
thought the
is,
same, doctor. I do thought the
so
same.
even I didn't know, even till MD, I didn't know this, sir.
Yeah.
So we don't even touch any of this. We keep an extra kidney here, and then we attach the ureter to the bladder. So this is another thing that many people don't know. Many of us also don't know. Many of us, I'm sure, even other fields in medicine also will not know that the third, it's kept as a third kidney. And the reason why this is done is, even with the kidney is in place, around 5% of kidneys will continue to function. It's even on dialysis, around 5%, around 100 ml of urine. Some people have even more amount of urine being produced. And we want to try and bring out as much function of the kidney as possible, which is why we don't meddle with any of this. We are okay with the kidneys being there. There are only rare conditions when we take out the kidney, wherein there is some infection which is not settling, where the kidney sometimes due to certain conditions are very enlarged. So you have a large kidney, you don't have place, and there are specific indications. I don't want to go into the details, but in such conditions you would remove the kidney, but otherwise it is always a third kidney that is transplanted. So this is another misconception, something is very interesting to note. And to slightly talk about the history of your transplant. So first thing, the luckily the first transplant happened between identical twins. So that immunology, that rejection, all of those concepts never happened. And from there on, now we have around 50 years, 70 years later, now we are into this entire new world of transplant where we have a lot of drugs which prevent rejection, and we are worried about rejection. We'll talk about rejection a little later. But so this is your transplant, how it happens. So if somebody is on dialysis and say her father wants to give the kidney, we have a lot of battery of tests that we do. We kind of run through these tests for both the donor and the recipient. If they are completely fit and we get all sanctions from the hospital as well as the government, we go ahead, we remove the kidney from this patient and we place it as the third kidney to the recipient. And once that happens, and what's fascinating to note is that somebody who was producing less than 100 ml of urine per day will end up producing 1 liter of urine per hour. And that is how, that is what, is every nephrologist's dream, is what we say, looking at that euro bag and seeing so much of urine coming out. So the other thing is this kidney doesn't have brain regulation. It's kind of a denervated kidney wherein you will not have complete regulation. They will not know. They just basically throw out all urine that comes to the kidney. So we end up marking urine output of 22 liters per day, 18 liters per day. As the urine keeps coming out, we keep putting in more fluid, more urine output, more fluid. And somebody who was not producing urine in one day will end up producing almost 800 ml to 1 liter per hour. So this is what a wonderful mode of replacement therapy it is. It's almost like on table you're curing somebody's kidney failure, which is why it's wonderful to have this idea of renal transplant in. And for us, the priority is always the donor, because though they are family, somebody who's absolutely fit, absolutely healthy, are coming forward and doing this altruistic act. So, as an nephrologist, we always say taking care of a recipient is important, but taking care of the donor is very, very important. Somebody should be. So, there are people who come to us anxiously and ask, "Sir, I'm donating my kidney. Is there some harm that I could face in future?" There have been various studies and various follow-up has been done through the years, and we have seen that yes, definitely there is an impact when you have only one kidney, but that your lifespan is equivalent to somebody who has both kidneys. And the only thing is that you should monitor your comorbidities like your BP, your sugars, your lipid profile, your obesity. If there is any protein leak, it is just like you're driving a car with lesser air in your wheels. You just have to be extra cautious and make sure that you're doing the necessary top up, you're on periodic follow up. That it's we as a protocol, we always make sure that the donor is doing well. At every follow up, we keep asking about the donor and making sure they're doing well. So this is about the live related renal transplant. The other option is, so not everybody, and this is again something that we're seeing commonly in our population now. Now we've almost switched over to a single child, no sibling family. So I feel 10, 20 years from now, we may not have as many donors as we used to 10, 20 years back. And it's very rare to see a 60-year-old or a 50-year-old mother or a father, somebody having no BP, no sugar, or no comorbidities. And so the donors pool is going to be a lot lesser in the coming years. This is something that the Western population are already having. So they don't have live transplants as much as we do in India. The other thing, that the option that they have is this diseased donor renal transplant. So if there is nobody in the family to give a kidney, the other thing that we do is they have to register in the statewide registry. So this is a huge waiting list. So it's around, the average waiting time is around 4 to 5 years currently in our state. It's probably improving because there was a major lag because we couldn't do transplants during COVID. and there was a huge pandemic, and giving immunosuppressant drugs were not at all an option. So transplant had stopped for around 1 or 2 years, and which is why the waiting list is longer. We expect that the waiting list should somewhere shorten between 3 to 4 years in some period of time. But there is a blood group based waiting list. So if you are starting on dialysis now, 1 to 2 months post the start of your dialysis, you can register on the state transplant registry. And based on your seniority for each blood group, when there is somebody, say there is an individual who has undergone, there is a car crash or some road traffic accident, they're on ventilator and they have been pronounced as brain dead. The family of this brain dead patient can say, I am willing to donate my husband's or my son's, my brother's organs to the community. In that way, after getting an informed consent and after the necessary formalities, each of these organs, based on which consent has been obtained, is retrieved from this donor, and that is rushed to the hospital. And for example, the heart, the lung, the liver, the kidneys, and based on this priority listing, this renal transplantation happens. And this is like a way for the patient who has come forward to know. So one patient who had an unfortunate event has given life to around 7 8 other people who are having an organ failure. So this is again another reason why we promote a lot of us to go ahead and do our organ donation, because sometimes things aren't in your hands. Sometimes you can't predict what could possibly happen. And when this event happens and you're already in a lot of turmoil and already in a lot of distress for you as well as the family, and for a family to come forward and take this decision is a great deal. But if that decision is made, it's wonderful that you although you are going through some untreatable condition, your organs are still working well. And if you take in the organ count from your eyes to your kidneys, 7 8 individuals are independently improving and back to their normal life because of this act. This makes it again, which is why again even the state transplant organization, we have like a parade for the donor when any time this retrieval happens in the state hospitals. So again, this is another thing that has picked up a lot of late, especially over the last 3 to 4 years in our state in Tamil Nadu and all over India. This has picked up a lot. And this is the other option. Somebody does not have a donor. This disease donor renal transplant is the other way to liberate somebody from your hemodialysis. And once transplant is done, is that the end of the story? So what I would generally tell my patients is like, transplant is like marriage. It's like getting married. All the halabala and all the gala event, all the preparation, all that will happen to that date, but then the journey starts after that. Yes, getting that done is important. Getting the timing right is important, but the real picture starts after the renal transplant. And what is important to understand when we talk about renal transplant is you're keeping somebody else's kidney in your body. So it can be your mother, it can be your father, it can be your brother. It's still a foreign object for the body. So the body has a tendency to fight against that particular organ. The body says, "What is this? Something new? Let me send out my antibodies and fight with that." But that should not happen. And when that happens, we have this unfortunate complication called as rejection. So to avoid this, we give a lot of immunosuppression, which is like drugs given to suppress immunity. There are some injection drugs which are given during the time of transplant, which is to rapidly suppress your immunity. And there are long-term drugs. So another thing that people don't understand is transplant. After transplant, you should not be missing even one tablet, even one time a day. You should keep your body constantly suppressed of your immunity. And there are obviously, I mean, the next question immediately would come from my patients: are there any side effects for these drugs? Any drug would have its side effects, but it's more of valuing your risks versus your benefit. And at this period of time, if by skipping a tablet you end up having a rejection and the kidney is lost, imagine that all these steps are going completely to waste. So, which is why it's very, very, very important that people maintain stringent surveillance. People come for periodic follow-up and people take their tablets on time. So the other question would be, if this is the case, why don't I overload myself on immunosuppressions? I don't want rejection. Why don't I just take a lot of steroids, take a lot of tacrolimus and other drugs? The other extent is you could end up having a lot of infections. So you would suppress your immunity too much, and then it goes into infections and the rare possibility of cancers in the long run. So this post-transplant tightrope, when you balance infection and rejection, is what the journey of a post-transplant patient is. So which is why taking pills on time, taking the necessary tests and periodic follow-up is very, very important. And patient should never think that, transplant is the be all end all, and that with that day the thing is over. It's like a marathon race where you continue to accept the kidney and continue to go about your routine work as well. So why I would wanted to point out these three stories was these three stories all started with a creatinine of 1.9 in one period of time. So this is the problem happens is sometimes we get a lot of these teleconsultations or we get sudden calls saying, "Sir, my uncle is in so and so place. His creatinine is 1.9. Tell me what medicine to take." It's not that easy at all. There are so many reasons why a creatinine for a patient could be 1.9, and there are so many ways in which this creatinine of 1.9 could progress. So to give you a summary, the initial patient present at 51 years, high BP, high sugars. At 58 years, he went in for dialysis. He wanted CAPD, so he was in CAPD. He didn't have anybody in the family for transplant, so he's on the DDRT waiting list as of now. This lady went in for native medication, some bone fractures. At 39 years of age, she went in for dialysis. Luckily, she had a father as a donor, and now she's following up with good graft function. The first patient who we saw who came back from the Gulf, he's been on OPD follow for a long period of time. And last creatinine is 5.3. So he has progressed to end stage renal disease. So in these patients, what we do is we tell them you do a fistula now itself so that you can get an access ready. It doesn't mean that if you do a fistula, you have to do dialysis. It is just that it is a kind of an insurance. It's kind of how you pay your health insurance. Doing a fistula is like that. You have an access ready. If there comes a point when you have symptoms, when you have a high potassium level, when you have low urine output, when you're very breathless and you want to initiate dialysis, it's a very simple way to start dialysis than putting a tube. So this is what we say a fistula first initiative. So patients who have an EGFR of less than 15, we start doing these fistulas in a preemptive way. If they have a transplant option, transplant is better. If they don't have a transplant option, we try to get them ready for dialysis. And the reason why I presented all these three was to tell you that, the same value of a creatinine of 1.9 is not the same for each individual, and each person goes through various complications, and most of our treatments are tailored to what goes best for that particular patient and that particular scenario and that particular patient's family support, and what form of dialysis would be helpful to them, whether transplant will be helpful to them, what form of transplant will be ideal. So it's very, very specific to a particular patient, and it's never as broad as, creatinine is 1.9, what drug can I take? It's never as simple as that. And which is why I would say, periodic follow-up and periodic visiting to the nephrologist and to your physicians. And what we promote now is primordial prevention, meaning that avoid it before it happens. So try and identify a high risk population, find out, especially with our changing lifestyles, it's becoming a major issue that, our processed food intake has increased. Now we say that, sitting is the new smoking. We don't move around a lot. Even we, as in doctors, are as guilty as patients. We sit in a desk and the entire day goes on that. So there are so much of our lifestyle which has changed and not in a healthy way. So identifying this high risk population, trying and detecting what is their comorbidities, getting their BPs under check, sugars under check, doing master health checkups. Again, people, there is always a contrary talk when people say it is a scam. People always have a negative view to healthcare. But what I would say is, we spend so much on so many things today. It's become we are no longer a saving economy. We become more of a spending economy, and we spend so much for so many things. And if we can't, I think it's very wrong if we can't take that effort to do a master health checkup to identify many of the things which are asymptomatic, like a kidney disease, and get our values clear, be aware about our numbers. That's very, very important. So, diet and lifestyle changes and restricting use of over-the-counter medications. This, I think, has reduced of late. I hope it has, because there's many times you see patients going to the pharmacy and just asking, "I have cold, I have cough, I have knee pain, give me the tablet." And so This is probably reduced because of some awareness. But again, as I spoke about, the indigenous medicines have again been a problem of late for us. And early treatment of acute kidney injury and following of those that survive from that acute kidney injury are all important. And if I want to tell you like five healthy habits, one is staying hydrated. So this is a very, very simple and easy tool that we don't do. Around 2.5 liters, 2 to 2.5 liters of water per day helps to avoid a lot of your dehydration, helps to avoid your risk of urinary tract infections, your risk of kidney stones. And this is very, very important. Second is you're getting a BP and sugar under control. Third is eating healthy, meaning lesser salt on the table. Say no salt on the table. Try and reduce the amount of salt that you cook and don't keep it on the table so that you don't have the habit of adding salt while eating. Avoiding your use of any painkillers or over-the-counter medications. And as I said, get your blood values checked. And this was a nice initiative that we had at CURI Hospital last year when we said know your kidney numbers. Because many of our disease, as I mentioned, is very silent. You don't have these symptoms till the end. So if you want to know, we always are worried about the heart, worried about weight, worried about your BP, because you know those numbers. So if you want to know your kidney numbers, just three things. Make sure your BP is under 120. So systolic blood pressure, which is the higher side of your BP, should be less than 120. Creatinine should be less than 1.2, and the protein leak in the urine. So this awareness about this protein leak isn't there. So kidney is like a kind of a filter, like a tea filter or a coffee filter. Small, small pores wherein water starts to get filtered and gets produced at urine. But with age and with BP or sugar, those pores start to open up and have some inflammation. Those pores get damaged. So beyond the water, heavier molecules such as protein start leaking, which is what presents as frothy urine or bubbles in the urine. People don't realize the symptom. People neglect a urine albumin or urine protein of trace or 1 plus in the urine. Even they say only 1 plus, what is it? What is that going to do? It's only trace albumin. What is that going to do? But it's very, very important that that urine protein is zero because that is an early marker of your kidney injury. So when this BP goes up, this could be a marker of kidney injury or could be an effect of kidney injury. When the protein starts leaking in the urine, that in the long run ends up causing an increasing in the creatinine. So if you want to make sure today that I okay sir, I am aware of kidney health today. I want to know if my kidney is doing well. What should I do? You don't need any magic test. Check your BP, check your creatinine, check your urine routine for protein leak, and maybe do an ultrasound alone. And if that is good, you needn't be worried at all. You can go about your routine activities. So this is just one final thought on acute kidney injury, and which is a very interesting patient who presented to us. He was a 26-year-old guy who we went to the gym, and they had some bet between them on how many sit-ups or push-ups you could do, and he ended up doing some 285 at one point of time. He came to us with high colored urine and decreased urine output to the extent of drop to less than 500 ml per day. He was a young boy, no comorbidities, absolutely good health, no smoking, no alcohol, no high risk behaviors. From creatinine of zero point 0.7, by just this single injury, the kidney is shut down to the level of 7 milligrams per deciliter. His creatinine went up to 7. We started him on hemodialysis. He required 4 to 5 sessions of dialysis. And luckily, the kidney started to regenerate function. And this is what is the condition called as rhabdomyolysis, meaning the muscle breaks down and causes a kidney injury. So this is a success story of hemodialysis. So his creatinine came down to zero point 0.8. It has been almost 8 months now. We generally follow them up strictly for the initial period of time. Now he's free from dialysis and he's very cautious about kidney health and he educates his friends. And what started as a bet, what started as a game, ended up to be such a dramatic change. His father came from Uttar Pradesh and he was somebody working in the army, and he was very surprised, shocked at this, and they were all very disturbed in the initial period of dialysis. But then he recovered. Not the dialysis did not cure the kidney issue. Dialysis supported the kidney's function. The kidney recovered with hydration, with the necessary treatment that was provided to him, and within 10 to 12 days, the kidney function recovered, and now he is doing very, very well, and he's on 6 months follow-up with us. So this is a different set of patients. So this is acute kidney injury, and this commonly happens when somebody is dehydrated, somebody has urinary tract issues, somebody has kidney stones, somebody has taken painkillers, somebody has worked out like this, somebody has had trauma. So this is a recoverable form of kidney injury. The other part, when this is not treated correctly, goes in for long-term chronic kidney disease. And sometimes not every AK recovers. This is another. So we've had an unfortunate event as well. Somebody had a snake bite. Snake bite caused a kidney injury, and due to a rare pathology, this did not recover, and that young boy ended up to having requirement for dialysis. And so what started as an AK doesn't always recover. So sometimes it ends up to be a chronic kidney disease. He required dialysis, and then his mother luckily came forward and was there to do a donor, and she donated her kidney, and currently touchwood the boy is doing well. This was another unfortunate story, but then again had a happy ending, and which is, I think, the message that we really keep promoting to all our patients. All our patients would always have some degree of a sorry story or an unfortunate event, but our role in most of these patients would be to always give them hope. You have an unfortunate event, you have a kidney shutdown, we have a hope of dialysis. You don't prefer hemodialysis, we have an option of a peritoneal dialysis. We have an option of a home dialysis. You don't want dialysis, you have a donor, we are ready, and there is an option of a renal transplant. If there is no donor, be comfortable on dialysis, and when it comes to your waiting list time, you will have another option as a transplant. So giving that hope and always giving that solution to our patient is where the actual world of nephrology lies. It ends up to be more of a therapy session more than anything else for most of our patients. And even for this patient, to be very honest, he kept asking me, sir, sixth day, seventh day, still my kidney is not functioning. What do we do? What do we do? To be very honest, even I wasn't aware if this kidney is going to recover or not. Yes, we expect it to recover, but we have seen patients who don't recover. So we also reassure him, and we also reassure ourselves that we just keep doing the right thing, and hopefully it recovers. And luckily for him, he ended up coming out of dialysis, and he is leading a perfectly normal life today. So just want to conclude by saying, your kidneys take very, very good care of you by working 24/7, 365. We should really be appreciative about your kidneys. And it's wonderful because no other organ in the body, we have two off and internal organ, and we have two off, and we just need only one for normal function. Which I would tell, whichever God or science or whatever you believe in, it's fascinating that they were so impressed by their own creation that they just decided, no, I want to just keep two in the human body. And somehow that idea has helped us to talk about donation and talk about kidney transplant. And it's wonderful what the kidneys do, and we should start taking very good care of them. And just the couple of images here. One is the Department of Nephrology in Madras Medical College, which inspired me and is continuing to be the one person the person that I am, or the things that I've learned is fully from there. And today, as part of CURI and the department there, and Muthu Jayaram ma'am and Ajay sir. So the hospital has also helped me learn and helped me uh, make that 1% change to patients that I see today. So yeah, this is.
Wonderful, wonderful, doctor, wonderful. And you have covered so many aspect and of dialysis, and then you have very nicely you build up the story, and then you went into transplant everything, and then transplant also is not a end of the journey, right? Again, post transplant also there are many things to be taken care, and all that you have very wonderfully covered, doctor. So I'm sure that all our viewers will take these lessons and take the kidney health and oral health for very, very importantly. They will take care of them. And I really wanted to thank you. I really
Thank you.
like the number of 120, 120 bar 1.2.0 actually. So thanks to Kiri also as well. And for coming up and giving this very easy layman. I'm not a doctor, I'm just an engineer, but I can relate that number very easily and all that. So kudos to the entire team who is working on this journey, very, very difficult journey. And I can sense it that by just merely listening it, I can sense that even doctor goes through a lot of calculations in the mind, everything and all that. So thank you so
We
much,
realize that you
doctor.
have to put something objective, and that's what makes it easy for somebody. We're very obsessed with numbers. numbers. We want to see a weight. We see a weighing scale today. We see 65. We see 68. Tomorrow we are shocked. We see 62. The next day we are feeling better. So it's always better when you, especially when you have an asymptomatic disease, you want to tell them that, and if you tell them to do 25 tests, nobody is going to be happy about it in today's world. So keep things simple, but at the same time, be aware. And, we many times we see this unfortunate event. Patient comes and says creatinine 3.5. Sir, now tell me what I should do. And by that time, it's too late. And, we feel like, okay, if only this patient had somebody to tell them this 5 years before or 10 years before, it would help so much. And even our chief used to say, the lesser patients we have, the better. But in our world, we're just going to keep having more and more, and it's unfortunate that way. So that screening, that primordial prevention, that avoiding kidney disease is something that we really want to push out to everybody. And I'm sure for people listening to this would have really helped them understand that our aim is only to make them understand how simple things are and how careful we should be about certain things. And to be very honest, I'm really happy that you have doing this as absolutely out of your own interest and passion. And people are just getting this knowledge from you, and it's a wonderful initiative. And I'm happy to be a part of it in some way.
Thank you so much, Doctor. So thank you very, very much. And any final message you have for any audience? Actually, you concluded, but any final message you particularly about kidney?
I think the main thing is adopting lifestyle measures, that keeping yourself hydrated, and keeping those dietary changes, keeping a lower salt. And also people who have kidney disease in the family, sometimes it's genetic, so getting yourself checked early, and periodic follow-up, and those are what are primarily important. The main thing is it doesn't cause symptoms, which is why kidney disease is something that should be spoken about a lot more than it is. Not many people know a lot about, we see about stroke, we see about brain, we see about heart, we see about lot. But because it's asymptomatic, because it doesn't cause problems, and it's only at later stage that we understand that the kidney has failed or kidney is losing its function, which is why that awareness has to be more. And services have improved a lot. And I would tell people that that is the strong message. There is always hope. Don't resort to some measure as an urgency. Don't go and get confused. I've seen people who are very well educated, very knowledgeable, but then they get bamboozled into some kind of a magic pill practice, and they lose follow up and take native medications. To be very honest, my one of my patients, he ended up to the stage that he was on follow up, and then he went up to, he reached to the point of dialysis, and his creatinine was around 8. And he said, "Sir, you've told me not to take any medicines for tongue. You're going to be, I'm going to dialysis now. Can you at least now try and see if these native medications work?" So people are somehow always fascinated by some alternative option, but it's never that easy. And and now it has changed a lot. There is no need to be fearful about dialysis. There no need to be fearful for trying a solution. The solution will have complications, but I'm sure a nephrologist will guide you through and will walk you through those complications with you. And that is what is the primary thing. And what I would say is find somebody that you really trust and build that patient doctor relationship better. I think that is where somehow over the last decade or so there seems to be a lot of friction. That prior patient doctor trust and relationship is probably breaking a bit or kind of fractioning a bit due to many reasons. And I think that should somehow, I think we are also responsible in many ways. So building that trust, back and say, okay, sir, I don't, as you rightly said, no, I am an engineer. So I wouldn't be a person who goes and says, let me fix the TV or the internet or the machine without having a knowledge. But somehow when it's healthcare, people have their own viewpoints, and people end up going the wrong path. So allow an expert to treat and make sure that you don't make any wrong decisions. And always understand there will be hope despite all your problems.
Yeah, only one message, Doctor.
Yes.
So especially with Dr. Muthu Jaraman, my mom, when she was alive and she was diagnosed with CKD4, and the relationship with the doctor and then the mother, I literally saw that actually. So I used to prepare a list of questions actually, what to be taken, what to be avoided, and I used to make a very nice graph of and how the creatine is going up and all that. I used to prepare very, very. for the meeting of Dr. Muthu Jayaram, I used to prepare a lot actually. So what happened actually? These two, mother and doctor, they sit together. They just talk a lot, and then it was making lot. I think more than the medicine and the trust. My mother built on doctor. Doctor builds on patient. I think it's a remarkable. And at the final one also, she didn't go through the dialysis, everything, and all that, right? So I think
And
when you touch upon that point, I'm very, very fascinating. Have a story of my mother and one. So always they literally talk each other, and then as though they are part of the family members and all that. I think in the beginning, when you said the word that Dr. Muthu Jaraman treats all the patient as a family member, and many of the viewer also have quoted the word called motherly advice and all that, right? So I can 100% vouch that statement as such, doctor. So I'm sure
And
that
that's
you will
another thing,
also
as you
become.
rightly said, wonderful, sir. As you rightly said, we always put the final decision to the patient and the family. So we realize that, there is no satisfaction in just saying, sir, your creatinine was 7, now it's 5, now it's 4. No, that doesn't give a patient satisfaction. They want to sleep well, they want to eat well, they want a good quality of life. There are people that we say no to dialysis also, even if science would say dialysis is best for them, if they are not willing or if they are not comfortable or if they are not happy with that option. Because just bringing down a number will not give you satisfaction if your sleep, your appetite, your quality of life is getting impaired. So there have been people who we've said withdraw dialysis. Dialysis doesn't work for you. So rarely we say, maybe age, maybe some factors, we say you stop dialysis. That's why I think respecting the patient's wishes and giving them what they want is what actually completes that loop. And that is something that I think ma'am also does very, very much for most of our patients.
Thank you so much, doctor, for all your time or for all your details, everything. I'm sure that this will be helpful for everyone. Thank you so much, doctor. Take good care of yourself. Thank you,
Yeah.
doctor.
Thank you, sir. Thank you for having
Thank
me. I think we've crossed the time that we scheduled, but yeah, we'll be
all
happy to answer questions or
lovely
anything.
nuggets,
You
sir.
can
All
contact at
lovely.
any time. Yeah.
Sure, 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 doctor. Sure, doctor. Thank you, doctor. Thank you. Take care.
Okay, sir. Yeah. Yeah. Thank you.